Hi, I'm Jennifer Martin, an ultrasound fellow at St. Luke's Roosevelt Hospital. Thanks for joining this SAEM narrated lecture. Today I'll be discussing ultrasound-guided peripheral IV insertion. Let's first review the objectives for my lecture today. First, I'm going to review the indications for using the ultrasound to aid in peripheral IV insertion. Then we'll review the techniques. I'll also highlight methods to confirm placement. And finally, we'll go through some pearls and pitfalls of this important skill. So let's first discuss some indications for ultrasound-guided peripheral IV insertion. Patients are sometimes known to have difficult access. They're commonly those who have systemic illness, including sickle cell disease, history of IV drug abuse, generalized edema. Then there's those patients who we don't necessarily anticipate to be difficult sticks, but have failed multiple traditional attempts at IV access. Let's move on to some background. As emergency physicians, we recognize the importance of obtaining vascular access when it's clinically indicated. And using the ultrasound can help assist in obtaining access when necessary and also help in avoiding central venous catheter when possible. Let's highlight some of the differences in risk between a central and a peripheral IV. First of all, central venous catheters have systemic complications, including bloodstream infection, arterial puncture, pneumothorax when you're cannulating the jugular or subclavian vein. Whereas a peripheral IV has a local complication, including local phlebitis and hematoma formation from puncture of a small vessel. And there's actually some literature to support this. The Mayo Clinic Proceedings in 2006 published this study, and they basically found that in patients who had peripheral IV compared to a central venous catheter, the risk of bloodstream infection was significantly less for every day they had the catheter. So the take home here is when it's not clinically indicated, we should try to avoid this riskier procedure when possible. And there's also some literature to support using ultrasound to help aid in peripheral IV access. In this Annals in Emergency Medicine article, Dr. Constantino and his colleagues found that ultrasound improves success rates in patients who have difficult success, decreases the time to cannulation from 13 to 33 minutes, and also results in fewer skin pricks. Let's move on to the technique and the equipment necessary to do this. First, you're going to need a ChloraPrep or similar sterilizing wipe for the patient, some sterile lubricating jelly, and your high-frequency linear probes to help visualize the vessel. Then you're just going to need your basic IV equipment, which includes a tourniquet, IV catheters of 18 or 20 gauge, preferably longer ones if you have, a saline flush, and a sterile dressing. Let's move on to the procedure. The first step will be to obtain your machine and choose the correct probe. Again, you're going to choose the high-frequency linear probe. You're going to remove any dirt and obvious fluid or other dirt using just soap and water. And finally, use a sanitizing wipe to just clean the probe off and sterilize it as best as possible. Now you're going to prepare your patient. Position your patient in a position of comfort for him or her with the ultrasound machine at the head of the bed so it'll be within your line of sight. You're going to clean the skin and apply a tourniquet as you would when you're doing a normal IV. Now it's time to choose a vessel. You're going to begin scanning in the patient's antecubital fossa, and you're going to scan proximally and distally, looking for a vessel. By moving proximally, you're going to run into the brachial and basilic veins, and they're often very large and quite tempting. However, beware, they're higher risk for infiltration due to their depth. Also, by scanning distally, you may find a more superficial vein, and that might result in increased success. This is just a short video that demonstrates scanning in the antecubital fossa both proximally and distally. So there's a current article that is in press for the American Journal of Emergency Medicine that investigated various characteristics of our vessel and the success rate and catheter longevity. This group here looked at depth of vessel, diameter of the vessel, as well as location, i.e. proximal versus distal, and how long the IV catheters were likely to last. They prospectively looked at patients who had ultrasound-guided IVs inserted in the emergency department, and they followed them for 48 hours during their inpatient stay. And they found that at 48 hours, the probability of a peripheral IV that was inserted using ultrasound as an aid had a probability of surviving of 0.63. And they found that depth and location were associated with increased longevity, meaning that the more superficial and the more distal the vessel was more, the IV was more likely to survive. So once you found a vessel that appears to be suitable, take a moment and follow the path of that vessel. You want to look and see where the vessel is most superficial. You want to look where its diameter is the largest. And based on that most recent American Journal of Emergency Medicine study, look where it is the most distal. Note here that the ultrasound machine is at the head of the patient's bed. The ultrasonographer is scanning an antecubital fossa, following that vessel, and looking for where it's going to be its best target. Once you've found a suitable vessel, let's ensure that it is a vein. And there are a few ways that we can do this. First, by compressing. A vein typically collapses with compression. Additionally, a vein will lack arterial pulsations when you partially compress. Note here compression and collapse of the vessel to the left of the screen. And the vessel to the right of the screen continues to pulsate with compression. Okay, once you've determined your vessel is indeed a vein, you may take one of two approaches to cannulate, the cross-sectional and the longitudinal. I'm going to begin by discussing the cross-sectional or short axis approach. Here, you can determine spatial relationships surrounding the vein, what's lying right next to it, an artery, a bone, a neurovascular bundle, etc. This also allows you to view tenting of the vessel roof as the needle is approaching. However, one of the drawbacks is that you may penetrate that posterior wall and not recognize it, and you'll still get flash. This is a short video clip demonstrating an artifact of the catheter within the vessel called ring down. Note that you see it right in the center of the vessel, and you can also see the vessel moving with the catheter inside. Now, the more challenging longitudinal approach is often desirable because you can follow the path of the needle as it is approaching the vessel, and you can note if you have posterior wall penetration. As I said, it is more challenging in that you are lying directly parallel to the vessel, and any move slightly off that axis could result in you penetrating an artery, thinking that it is your vein. As we said, it is more challenging. Note here that the probe is lying in the longitudinal plane, and the vein would lie directly below it and look like so. Now, as you're approaching the vein, note from the left you see a catheter popping into that screen. Note how you could see this as it's approaching your posterior wall and thus avoid posterior wall penetration, which is clearly an advantage to using this approach. So, investigators actually looked at short versus long axis approach to an ultrasound-guided IV insertion, and they found that the success rate is greater using a short axis approach, and time to cannulation is also less using the short axis approach. Okay, let's cannulate the vessel. First, use the short axis and determine the spatial relationships surrounding your vessel. Is there anything nearby you need to be aware of? Now, I'm going to use a simple high school math equation to help us determine the best way to approach. When your vein is deep to the skin, your catheter is a distance, which we're going to call A, above the vein. Not your catheter, your ultrasound probe. And your catheter is going to be a distance B away from your ultrasound probe. And the hypotenuse of your triangle is going to be a distance C that your catheter is going to travel to successfully cannulate the vein. Remembering the Pythagorean theorem from high school, a squared plus b squared equals c squared, and recalling a 30, 60, 90 triangle, we can determine the appropriate distance to place our catheter away from our ultrasound probe to ensure successful cannulation. Now, recall that you should always center your catheter with the probe. Hold the probe in your non-dominant hand, the needle in your dominant hand, center. And as you're approaching in the short axis, look for tenting of the vessel by your needle, as demonstrated in this below video. Once your catheter is in the vessel, you may see the ring down artifact, helping to confirm you're in the right spot. So, once we've had successful cannulation, let's confirm we're in the right spot. By moving proximal to the vein with your ultrasound probe and flushing your catheter, you could see hypoechoic microbubbles fill the vein. This video demonstrates that example. The lower left of the screen, right by that arrowhead, you see flush and bubbles filling that vessel, which is helping to confirm you're in the right spot. So, we've reviewed the indications for performing ultrasound-guided IV, and we've also reviewed how we're going to place it and confirm its placement. Now let's just go through some pearls and pitfalls of the procedure all in all. Again, look for that target sign when you're in the short axis. That is your needle catheter within the center of your vein, and that you can see in the short axis. Don't rely on flash alone. That also can happen when you posteriorly penetrate the wall. Remember to ensure you can withdraw smoothly and flush smoothly without infiltration. Using those longer catheters will increase your success rate. If you don't have access to long IV catheters, consider using an A-line kit. And finally, think about those superficial distal vessels. Thank you very much for tuning into this SAEM narrated lecture. I hope that you learned something and you can implement it in your daily practice. And I'd also like to thank Risa Lewis, Lorraine Ng, Turin Saul, and Megan Herbst for their help in developing this lecture. Finally, here are some references. Hopefully you'll find them helpful. Thank you again for tuning in.